Thank you for this august audience for being present here after such a wonderful banquet that we had. We primarily are going to talk about an important topic, which is about sleep. Of course, as you know, it's a sleep symposium. There was always a question which arose as to we always look for Western literature, we always look for Western guidelines to talk about what do we need to do in India with regards to sleep. So starting from this question, we decided, can you put up the slides, please? Yeah. Starting from this question, we decided, why do we not derive Indian sleep guidelines for Indian children specifically, which helps us? Remember, there are a lot of scientific guidelines which are being presented world over. But what happens is sleep is very culture specific. It is resource specific. So it depends a lot on what is happening in India. And it was high time that we started speaking in India as the National Respiratory Chapter to say that we are going to start producing basic consensus statements within our own organization, which we as a group can start communicating to our pediatric population. So I'm privileged to have three of our experts today. Dr. Mahesh unfortunately had to leave because he had a flight last night and he has left for the day. But we have three others with us, Dr. Indu Khosla, who all of you all know, Dr. Sanjay Bafna, and Dr. Preeti. Dr. Indu has been doing excellent sleep work in Mumbai. Dr. Sanjay Bafna has been doing already a lot of sleep work in Pune. And of course, Preeti has started sleep work in Jaipur as well. So going through the introduction, you've already had a lecture on sleep. We have understood, at least from Dr. Sadashivan's lecture, that sleep problems are very common, right? The prevalence that we have done a review of literature shows world over it is 21 to 47%. In the US, they pulled out data of children who are going to a sleep clinic, and they found that 3.7% children who are attending a pediatric clinic had an ICD diagnosis of a sleep disorder, which means that 4% of people who are walking into your pediatric OPD have a diagnosable sleep disorder, which we are not diagnosing. So we go to the different literature of the prevalence of sleep disorders. Primary snoring, as we covered, 5 to 27%. Yes, Indian data is there, and we show it is around 27 to 30%. Obstructive sleep apnea ranges from 1 to 7%. Behavioral insomnia of childhood, which we will talk about, 30%, which means 1 out of every 3 infants who are walking into your OPD has behavioral insomnia of childhood. And parasomnias range from around 5 to 35%. So although we spoke about snoring and OSA, it's important for us to understand that sleep issues are not only obstructive sleep apnea. There are multiple sleep issues that we need to address as pediatricians. So in March 2023, we received the invitation by the IAP NRC, the president, to create an expert consensus by me, by Dr. Bharat Reddy, and then we created an expert group with core experts, Dr. Indu Khosla from Pune, Dr. Maya Ramgopal from the US, Dr. Sanjay Bafna from Pune, Dr. Eileen Kinimi from Bangalore, and myself, Dr. Bharat from Bangalore as well. We had chosen few expert reviewers of this. Dr. Mahesh Babu from Singapore, Dr. Stephen Hawkins from US, and Dr. Benjamin Hughes from US have reviewed it. And the IAP approvers were Dr. B.S. Sharma and Dr. Jagdish Goel. We held our first meeting in May 2023, and we developed the questions which need to be answered. What are the questions that pediatricians like you have about sleep? What do I need to do about these patients? In June 2023, we had a comprehensive review of literature, and we formulated 20 questions. We divided them into primary and secondary experts for each topic. Each core person expert received 4 questions. They went through review of literature extensively. Now remember, what happens is we don't have sufficient Indian data to go through the regular guideline process. So which is why we decided that this will be an expert consensus statement. September 2023, we held the meeting, and we had a detailed discussion of each question, finalized the expert consensus, and we're here in November 2023 presenting it at RespiCon 23, and by December 23, it will be published for all of you to start reading and implementing by year 2024 in your practice. So let's go on to the consensus statement as well as the questions that need to be answered. So first question which we found a lot of pediatricians were asking was, what is the recommended duration of sleep in children, right? So this is a very important question. We found that a lot of people said, if we need to talk about this in our pediatric practice, how do we advise the children? Starting with the first question to Dr. Indu. Why is sleep, first of all, important? Why are we talking about duration of sleep in children?
Yeah. So I think sleep is essential, and it's a neglected thought process with most. And sleep is essential because it is a restorative process. Not only it restores the mind, it restores the body. It consolidates memory. It consolidates new learning. In children, it is responsible for growth because we all know growth hormone is secreted in sleep. And it is also, in a way, important for prevention of allergies because of so many of the circadian rhythm in the body, which is disturbed if you don't sleep properly. So sleep duration is important for it to be restful. So when we say a healthy sleep, a child sleeps for an adequate duration, which is recommended age-wise, which we'll come to later. And a person should get up in the morning without feeling fresh, without any night awakenings, and the person also should feel completely rested. So correct duration, correct technique of sleeping without awakenings, and a next day which is not drowsy and completely the patient is restored. So that is why sleep is important.
We definitely agree that the duration of sleep is important to decide that neurocognitive effects are closely related to the duration of sleep as well. So Dr. Preeti, what is the current recommendations for duration of sleep as per ASSM? I think I'll put up the slide for the convenience of the audience as well.
So actually we still don't have Indian data about the recommended duration of sleep hours. We have seen like sleep is important for the overall growth as well as physical as well as the mental growth of a child. We still follow American Academy of Sleep Medicine guidelines for the pediatric age group. For the infants from 4 months to 12 months of age, what they recommend is 12 to 16 hours of sleep per 24 hours, which should include all the naps during the day. Children between 1 to 2 years of age should sleep for 11 to 14 hours, including the naps within 24 hours. Children for 3 to 5 years of age, they have still, like their toddler age group, they will start going to school also, but still they require some 10 to 13 hours of sleep, and they still continue with napping also. They should include the napping hours also. Children with 6 to 12 years of age should sleep for 9 to 12 hours as per their family preferences, schedule and all, but they should try to at least get 9 hours of sleep per day. Minimum 9 hours should be there. For the adolescent age group, is little more difficult to get it, like some 13 to 18 years of age group, but still it is recommended some 8 to 10 hours. They should also.
Sure. So what was derived was the American Academy of Sleep Medicine as well. How do they get these numbers? They got these numbers primarily again by expert consensus, right? Because it's very difficult for you to exactly get scientific studies which are going to tell you your exact duration of sleep. So as experts, we decided that till we have sufficient Indian data, I think we need to start adapting the ASSM guidelines itself for the duration of sleep till we're able to generate adequate data of what is culturally appropriate for India. But we have noticed world over, although the ASSM has done Western and Asian data, this is the recommended duration of sleep, and we have to follow this as a global requirement and ensure that this is the number that we will follow. Dr. Sanjay Bafna, if we're talking about this much duration of sleep, a lot of pediatricians came up with one question. What is the recommended bedtime and what is the recommended wake time for Indian children that you would recommend?
So here I think we are talking of sleep schedule, and it is one of the important component of your sleep hygiene which we are going to discuss. So when we are talking of this schedule, I think the recommendation would depend upon the duration which we have just discussed. So the bottom line here is basically the child should be having adequate sleep duration, and therefore your bedtime would depend upon various factors. So it would depend on the age. It would also depend upon the family practice or the cultural practice or the family schedule, school timing, and the duration of nap. So having considered that, you should recommend a schedule which would fulfill the sleep requirement for that age. So roughly, I mean, in Western population, the bedtime is much earlier, maybe 7 or 8, which is practically not possible in Indian settings. So I think we came up with the suggestion that maybe we can fix up a higher level, maybe 8 to 9 for younger children and 9 to 10 for older children. But you need to backdraw that from the wake time. So you need to know what is the wake time, and then you can calculate that bedtime.
As you mentioned, because wake time and bedtime are so culturally dependent, it becomes very difficult to say get your child to sleep at 9 or get your child to sleep at 8, because that is not practical for you as a pediatrician to even advise the parent. So the best method, like Dr. Bafna mentioned, is take the duration of sleep that we mentioned. Suppose this child requires 10 hours of sleep. You calculate the wake time. What time is your child waking up every day to go to school? My child wakes up at, let's say, 6:30 or 7 o'clock. So backtrack it from there. If 7 o'clock is the requirement for your child to wake up, you cannot change that. You cannot make your child wake up later. From 7 o'clock, you backtrack 10 hours to 11 hours. So it'll be 7, we'll go to 12, and 3 hours extra. That means your child should sleep at 9 o'clock for your child to wake up at 7 o'clock and get 10 hours of duration. So this is important for you to discuss with your parents, and this is a formula that we feel works across cultural barriers. The reason we realized was India itself is so diverse. So you cannot even give a broad exact bedtime for people across India, but this is the method which you can calculate the bedtime and the wake time. So consensus was, we recommend to follow the American Academy of Sleep Medicine guidelines for the duration of sleep due to paucity of Indian data. And culturally, India is too diverse for us to differentiate in different areas. But determining of the bedtime should take into consideration the age of the child, the wake time of the child, and the family schedule, and then you start advising the child on the bedtime and wake time. Going on to the second question, which a lot of people asked us, is co-sleeping discouraged or encouraged? A lot of Western literature says co-sleeping is not encouraged, but in our studies we have shown that 90% of our Indian children co-sleep. So going to you, Dr. Indu, can you tell us what is the difference between bed sharing and room sharing? Are they different?
So I think it's pretty obvious with what the question is. Bed sharing is when the child and the parent, the mother or the father, sleep in the same bed. And room sharing is when the child and the parent sleep in the same room but in a different bed. So there is a difference because this is more actually, as Dr. Bharat already pointed out, it's more pertaining to the Western world where the risk of SIDS was higher. So when the risk of SIDS was higher, bed sharing was a problem, and room sharing was not that much of a problem as much as with bed sharing. So there is a difference in bed sharing and room sharing, as the name suggests. So
what are the advantages? I think it is an overlap. Yeah. What are the advantages and disadvantages of both of these forms of co-sleeping?
So I think we are culturally different, and if you and we all are aware that our children sleep with the parents for a very long time, and it's not uncommon for us to find an older kid still sleeping with the parent. The advantage is close bonding with mother and the child. Mothers who are breastfeeding, it's very convenient for a mother to breastfeed the child. A proper monitoring of the child through the sleep these are the advantages of co-sleeping. And there are studies which have shown that even if the baby is sleeping with the mother and even breastfeeding through the night, especially for the first couple of months where it is recommended, it really does not hamper the child's sleep. That's not true when the child gets older and keeps getting up for feeding. So these are the advantages and for the baby. The disadvantages of co-sleeping is SIDS, which is seen in the Western population. We have not seen, and the studies there also now reveal that it is probably the caregiver, the mother, who was probably consuming drugs or alcohol, and therefore the risk was higher in that category of patients. The other disadvantages on the personal life of the parents, that is also important. And of course, that is the other disadvantage that we must keep in mind. And of course, the other disadvantage of co-sleeping could be if the child is getting up again and again, it is going to disturb the parent's sleep also, the child's sleep and the parent's sleep. So these could be the disadvantages. Sure. Beyond a certain age, it is recommended that the child would sleep separately because it is again important for his neurodevelopment.
Sure. So the topic again, when we say co-sleeping involves two things. I hope you understand. It involves either are you co-sleeping with bed sharing or are you co-sleeping with room sharing. Now again, when we spoke about the Indian population, certain houses may have only a single room. You're not going to tell them, say, or one bedroom house. You're not going to tell them put the child in another bedroom. So it's very difficult for us to say put children in another bedroom altogether as a broad guideline. So it is accepted that yes, bed sharing may not be something which is recommended, has its own disadvantages, but room sharing may not be inappropriate in terms of psychological bonding as well. So based on our data, we did find that one, in India, the decision has to be left with the family. Whether to co-bed or co-sleep should be based on the family preferences. You understand all the safety conditions as well as the individual needs of the child, keeping in mind from healthcare professionals, cultural norms and practices within your specific region. And it's very important for you to give this choice to the parents and explain the concept of bed sharing and room sharing and how after a certain period of time, the child needs to stop bed sharing, start with room sharing and then shift to a different room as well. Going on to the next question which came up, what are daytime naps recommended for children or not? Dr. Sanjay Bafna, what are the benefits of naps in children? Why should a child even nap?
So, coming to the physiology of naps, basically, we all know that infants would have 2 to 4 naps in the first year of life. And then as it progresses, this is a polyphasic sleep where you have multiple naps, which progresses to biphasic sleeps, where you have 1 to 2 naps a day. And by the time the child is 5 years or maybe 7 years, the nap ceases. So this is an important developmental milestone actually. It's not just that it is the pattern, it's a developmental milestone and it is required because naps are supposed to have a beneficial effect on cognition, on consolidation. Brain uses that opportunity to synthesize information and it helps for neurocognition. But beyond the age of 2 or 3 years, this is not required by the brain and therefore nap loses its importance after this period. In fact, there are studies to suggest that if the child is still napping after, he's become older, your bedtime is pushed, your duration of sleep is affected, and in fact, it may have a detrimental effect. So earlier on, it is definitely beneficial, but at some point, you need to stop.
Thank you, Dr. Bafna. So the total recommended of sleep, whatever you mentioned, the total duration, remember it includes the nap time as well. So you need to calculate nap time plus night sleep and together calculate the total duration. And the consensus that we reached was, although most children should stop napping by the age of around 5 years, is the time that naps should be dropped. Nap preferences can be different for different children. If the child is napping regularly till the age, even after 7 years of age, that indicates that there is a sleep problem in this child, and sleep history needs to be considered to rule out underlying sleep health concerns in this child. What are the sleep hygiene recommendations in infants? I'll take this topic because I was the one who prepared the details for this. So we spoke about sleep hygiene in infants, school-going children, as well as adolescents. So what do you need to do in sleep hygiene in infants? We need to first set a consistent sleep schedule. Consistency is the key to sleep hygiene in a lot of children. We set a bedtime and a wake time, ensuring that the infant obtains recommended duration of sleep. Maintain bedtime 7 nights per week with minimal variation for weekday and weekends, even at an infant level. Maintain a consistent bedtime routine daily. A bedtime routine is a bedtime chart which helps a parent provide consistency and implement standardized routine 2 to 3 activities over a period of 20 minutes, including baths, stories, and songs. We need to provide verbal cues such as nap nap, shush shush, at least 1 to 5 minutes before bedtime, thereby giving children the message that the time for sleep is nearing. Allow a child to self-soothe by avoiding negative sleep associations such as rocking, feeding to sleep, and walking around. Maintain a consistent nap time and end time, and ensure your nap ends by 4 p.m. No child should sleep beyond 4 p.m. to ensure that infants get ready for early bedtime, and avoid all forms of digital exposure up to the age of 2 years, as digital exposure interferes with sleep. So this is the infant sleep guidelines that we have created, and all these 8 steps need to be counseled for all your infants who visit. So sleep hygiene practices, as the above steps, should be advised to all infants that come to you during their well baby visits to prevent infant sleep problems. You of course get children who come for vaccination. Just print these infant sleep guidelines probably as a single brochure and give it to all the infants who are coming to your vaccination clinics. So going on to school-going children, I think this Dr. Preeti can take. What are the steps for ensuring school hygiene in school-going children? This is for infants. Let's say a child is almost like a toddler age group. Can you highlight the recommendations?
So basically, we have seen like consistency is very important. Nowadays, what is happening, kids, they are, because of their extracurricular activities and all, they are not able to sleep in time, they are not able to, and then they try to cover up that sleep on the weekends. Basically, they sleep for the longer duration on weekends. So your bedtime and wake time should not differ by more than 1 hour. Actually, you should maintain a consistent bedtime as well as the wake time on the weekdays as well as the weekends. That is 7 days a week. That is the first and the foremost most important point. Second, we should avoid electronics as well as any high intensity activities like running or playing outside or playing some energetic game. These all should be avoided. And screen time also should not be there for at least, it should be avoided for at least 30 minutes to 1 hour before going to sleep. So kids nowadays what is happening is kids, they are using beds for each and everything. They are playing on bed, they are doing their homeworks, they are doing and eating on bed. It should be stopped at all. They should be focused. They should realize that beds are only meant for sleeping, and when you go to bed, it is basically your mind should be primed that it is meant for sleeping, and now it's time to sleep. So, and the child's bedroom should be kept very cozy, comfortable, and temperature as comfortable to the child. It depends upon child to child. Some kids, they feel cold temperature is very comfortable, and others might feel comfortable at average temperature. So plus a set of activities, as Bharat has already focused, some 2-3 activities before going to bed. They should be done, you can ask child to change the pajamas, you can read a story for your child, and that schedule should be followed. That 2-3 activities are to be followed in the same order daily, so that the child also gets primed that now this is I'm preparing for my sleep and I'm supposed to sleep in time now.
Sure. So I think we all understood that school-going children must be counseled, and this is important that, of course, like Dr. Sadasham said, we take history, but how many of us are counseling every single child about good sleep? Because sleep is an investment is what you learn. So all school-going children must be counseled on the steps that we mentioned for maintaining adequate sleep duration and good sleep hygiene. And as you know, pediatric is a very different group. So we come to the next group, which is adolescents, which I think Dr. Indu can take. First of all, before we go into adolescents, why is the sleep guidelines different for adolescents versus infants versus children? Is there any difference in the physiology of children versus adolescents with sleep?
So there are differences. First of all, the requirement of sleep in adolescents actually goes up because again it's a growth spurt, a pubertal growth spurt. So the requirement of sleep is higher. The second thing is their sleep onset is pushed a little later. So they physiologically get later sleep. And then they exploit that and push it further because of their social media interactions, their Facebook, their Insta, etc. So then they sleep even later. And when they sleep later, since their requirement of sleep is higher, they want to wake up later. So I'm sure in this audience there are many people who have adolescent children and you find it so difficult to wake them up in the morning. The other problem is this is the time when they're consolidating their careers, so they have a hectic schedule. So they always get lesser sleep than they actually their body demands. So this is a problem in adolescents. So again, it is very important that we maintain a good sleep hygiene in adolescents. Because if you see as your children are growing up, by the time they're 8, 9 years of age and by the time they start using digital media, they will slowly start sleeping later and later. And that is the time to start acting on them before they actually get into this something called as sleeping late and getting up late schedule. So you should maintain a consistent and a regular bedtime like how we've mentioned for younger kids. But here also it's important to maintain a consistent regular bedtime and wake time schedule on all days. Now there will be adolescents on weekends who would like to go out. And when they go out, they will come late and they would want to sleep late. So even in weekends, when they come and sleep late, I think you should bargain with your adolescents to say, okay, if you're going to sleep late, but you still have to get up in the morning, maybe half an hour, 1 hour more than your regular schedule. So that way you will maintain consistency on weekdays and weekends. So the difference should not be more than an hour on weekdays and weekends. One should avoid electronics, very easy to say, difficult to get done, but you must try to achieve that, you avoid electronics and screen time at least half an hour before bedtime, because the blue light emitted from screen is detrimental to getting sleep. Physical activity is a must for adolescents, but it should not be 30 minutes to 45 minutes before bedtime. So it's a good idea to have physical activity in the evening. The bed should be used only for sleeping. We have already emphasized on that. Because if the thought, especially if they use it for any other activity, then it leads from one to the other and then it delays the onset of sleep. And they should have a regular winding time down to go to bed. The bedroom should be comfortable and it should be a quiet bedroom for them to go to sleep. And also they should avoid eating late meals. Avoid caffeinated drinks after 4 p.m. Many adolescents tend to have these energy drinks, caffeinated drinks. So that should be not given after 4 p.m. so that once they get into bed, they can get sleep. Next day morning, if you expose them to light, so you just draw the curtains, you expose them to light in the morning, that helps them to wake up. So that's another thing that you can do to ensure a proper circadian rhythm. And if they have if many of the children in our country are driving at the age of 16, so if they have not had an adequate sleep, it's best to avoid driving on the next day to avoid accidents.
Sure. Of course, we'll be releasing all these statements for you in a month. So I find many people are trying to take pictures and finding it difficult. Don't worry, we will be releasing this as a publication pretty soon. So the factors, what you need to understand is adolescent sleep is different from infant sleep and childhood sleep. There are various factors in the adolescence which cause reduced sleep by itself, and we need to recognize that and ask for them. And counseling all adolescents and sleep hygiene is extremely important because it makes a difference in overall well-being and academic performance. So what are the recommended steps for sleep coaching? Now suppose an infant is not sleeping, so we have decided that we have come across with certain fixed steps which help infants to go for sleep coaching. I'll go through this a little faster. We have to understand the concept, explain the concept to parents about 3 things. What are sleep associations, what is self-soothing, and what is sleeping through the night. Sleep associations are any object or any activity that a baby associates with sleep, like feeding and rocking. Self-soothing is a developmental milestone that the baby needs to attain by ensuring that the child can go to sleep on his own, and a child should not be waking up multiple times. That is called sleeping through the night or consolidated sleep. So the parent needs to understand that sleeping through the night is extremely important. There are two types of sleep coaching that we usually counsel on. One is called the extinction method or the cry-out method, and the second is the graduated extinction method. The parent should be given the choice of whether you want to use the extinction method or the graduated extinction method. The details of this we will be publishing and sharing with you as well, and a parental choice needs to be considered into this sleep coaching. But what we have also found that sleep training or sleep coaching is beneficial for infants, and there has been no long-term detrimental effects, and there are no negative aspects of sleep coaching and should be implemented in children. Going on to a few more important topics due to shortage of time, I'm going a little faster, I'm sorry. So how is OSA clinically suspected or diagnosed? So right now you covered an entire spectrum of sleep till now. Going to the next part of it where we're talking about OSA, clinical diagnosis. I think because Dr. Sadashiram's talk is already done, Dr. Bafna, you can take this in a little faster manner. So as per the research, what we did and the review of literature, what are the clinical signs and symptoms of sleep disorder breathing?
So just now we heard a wonderful talk on OSA. I think it's elaborated that it's a spectrum, and it may start with a very, very mild symptoms like snoring, mouth breathing, and you have daytime and nighttime symptoms. So nighttime it impacts your sleep, and it impacts your, daytime it impacts your behavior. So you may have just mouth breathing, snoring, but then comes a restlessness, abnormal positioning, child is sleeping in a sitting position, all this, and then of course the extreme where there is gasping, paradoxical breathing, and apnea which you notice. Daytime it has an impact on your neurocognition, so children would not, like adults, there is no excessive daytime sleepiness. They are more hyperactive, they are more irritable, there is learning disability which is noticed, and on physical examination, of course, you would see adenoid facies, there may be failure to thrive, obesity, the child may have systemic or pulmonary hypertension, and then of course, there may be risk factors of the OSA which you may diagnose on examination. So these are the usual things which you will get on examination.
Sure. So this is the table that we'll be releasing for you, where you can start keeping this table with you and say that these are the nocturnal symptoms, these are the daytime symptoms I ask, and this is the physical examination I'll do in children with suspected sleep disordered breathing. I think this is a term which is new for the audience, Dr. Preeti. Is sleep disordered breathing the same as OSA?
No, basically sleep disordered breathing is a wide umbrella term. It will include any breathing problem occurring during the sleep. It will include any obstructive event, any central apneic events, as well as the hypoventilation. Whereas the obstructive sleep apnea is basically only referred for the events in which there is partial or intermittent complete obstruction to the breathing occurs, and it will disrupt the normal sleep pattern and the normal ventilation. And this fragmented sleep, intermittent hypoxia will lead to what signs and symptoms we have already, sir has elaborated.
Sure. So the difference that we need to understand is that sleep disorder breathing is a clinical diagnosis, whereas OSA is your diagnostic diagnosis, which means that for you to establish a diagnosis of actual OSA, you need to do a sleep study or a polysomnography, whereas the entire spectrum that we spoke about in the previous talk, right from primary snoring to OSA to hypoventilation, all comes under a spectrum called sleep disorder breathing. So you need to start changing your terminology. So when you write you're suspecting any such events, you say suspected sleep disorder breathing, and if you're saying it is OSA, it has to be diagnosed on a polysomnography. So we need to understand that routine screening for SDB is essential in pediatric practice. Detailed history. Suppose you do a screening for sleep disorder breathing, then take a more detailed history in this child, and polysomnography is required for the confirmation of obstructive sleep apnea. So these are the two terminologies that we need to change across our country right now. So what are the different diagnostic modalities for pediatric sleep that we have? When we talk about PSG, we have different levels. We have level 1, level 2, level 3, and level 4. So we need to understand that PSG is not just polysomnography, is not a single term. We have different levels of sleep study. What is available in your city needs to be understood. So what we do and where we need to understand that. So we have different respiratory indications. So I'll go to the basic indications that we recommend for PSG. Firstly, in clinical assessment for children with a diagnosis of OSA or a suspecting sleep disorder breathing, after an adenotonsillectomy, if a child comes back to you with obstructive sleep apnea symptoms, or before adenotonsillectomy, if the child has risk factors, if you're planning to do a titration of your positive airway pressure, if the child has any acute life-threatening event, children with neuromuscular disorders, and follow-up in children who are already on NIV. These are the respiratory indications for polysomnography. The non-respiratory indications for polysomnography are in children suspected to have periodic limb movement disorders, preceding a sleep latency test for narcolepsy, and other forms of epilepsy, suspected epilepsy, or you're suspecting some parasomnia with associated OSA. Remember, parasomnias, we don't do PSG. Only parasomnia associated with sleep disorder breathings, we do PSG. So these are the respiratory and non-respiratory indications when you refer for a sleep study. So if there are no symptoms at all, Dr. Indu, which are the conditions where I would refer for a sleep study if the child, we've taken sleep history, there are no sleep symptoms, but should I still refer for a sleep study?
So the first and foremost, I think the commonest that we see is Down syndrome. So if you have a child with Down syndrome, the ASM, the American Association of Sleep Medicine, recommends a sleep study to be done in all children by the age of 4. And this recommendation comes because almost 50% of children with Down syndrome will have some form of sleep disordered breathing. And by the time they are adults, almost 100% have sleep disordered breathing. Then if you have children with craniofacial syndromes like the Apert syndrome, the Cruzon, the Pfeiffer syndrome, they are again at a very high risk of developing sleep disordered breathing. Then you have children with obesity syndromes like a Rohard-Net syndrome or a Prader-Willi. In Prader-Willi, you need to do a sleep study before starting growth hormone therapy. Then if you have children with neuromuscular disorders like your SMAs or your Duchenne's myopathies or any other myopathies, in these kids, when you have a dropping lung function, an FVC which goes below 60%, sleep study is mandatory because you will change the life of the child because the pulmonary morbidity will go down. Any complex OSA, in the sense if you have a child with tonsil adenoid with obesity, that is a complex OSA. In these kids, also even if you don't, and many a times what happens is parents don't realize that the child has symptoms because the child is sleeping in the next room, and the typical sleep disorder breathing symptoms come in later part of the night, more during the REM sleep. So if you have a setting for an OSA, and even if the parent does not complain or has not noticed, one should do a sleep study.
Sure. So there are specific conditions that we will be releasing where you need to do a sleep study irrespective of the sleep symptoms. So yes, we spoke about indications with sleep history, and there's indications irrespective of sleep symptoms where you have to go ahead and do a polysomnography. So can we get away with just a video recording? Do we really need to do a polysomnography, Dr. Preeti? Does a video recording help in any way of a sleep disorder?
So I would not ignore a video recording. So if a patient in the night gets me a video recording of a child with an abnormal posture or a noticed apnea, it definitely aids in my diagnosis. Sure. But it does not tell me the severity of the sleep disorder. It does not tell me how I should manage this child in a more effective way, whether I need a medical management or a surgical management or a management like using non-invasive ventilation. So I encourage parents to get me a video audio recording, and that could be a lead point to take it forward.
So though we do PSGs, we also need to ask for video recordings because it definitely aids us. So the choice of sleep study depends on the level of on the indications as well as the suspected sleep disorder. You choose between the 4 levels. As per current guidelines, what you need to understand is HOPE sleep apnea testing is not recommended in our country as of now. In specific genetic and neuromuscular conditions, sleep studies are recommended irrespective of sleep symptoms, and home video recording can serve as additional or supplementary tool for children with suspected sleep disordered breathing. Now the next question which a lot of pediatricians have and who come to us is, when do you choose surgical versus pharmacological treatment in obstructive sleep apnea? Do I need to go for surgery? Do I need to give medication? What do we do? So back to you, Dr. Indu. When is pharmacological treatment chosen, and what pharmacological treatment can you choose?
So if you have children with mild OSA, so if I say mild OSA, actually it is a diagnosis on polysomnogram where the AHI is between 1 and 5. But if you have children with mild OSA, children who have allergic rhinitis as a predominant symptom, in these kids one can look at pharmacological management in the form of intranasal corticosteroids with or without montelukast. But this is the only subcategory of children where I would look at a pharmacological management. And if the child does not respond to this, then of course we need to step up our treatment. So you can give a trial, maybe for 6 weeks to 3 months, and see if your child responds.
Sure. So we classify as mild, moderate and severe. So OSA is classified as mild with an AHI of 1 to 5. AHI stands for apnea hypopnea index. 1 to 5 is considered mild, 5 to 10 is considered moderate, and more than 10 is considered severe. As per studies, only in mild cases of OSA, pharmacological pharmacological treatment shows to have therapy.
Yeah, and
Moderate
this
to
is
severe,
also in simple OSA that we are talking about. If you have a child with tonsil or adenoid with obesity, or you have any other risk factors,
Then we need to go
I
in
would
for
probably not consider pharmacological management
therapy.
without further
Sure.
investigation.
So Dr. Bafna, then do I do a PSG before adenotonsillectomy and after adenotonsillectomy? Because parents are going to come to you asking, do I need to do a PSG or not do a PSG before I go for surgery?
So why do we do PSG in OSA? Basically for two reasons. One is for diagnosis, confirmation of diagnosis, because it is a PSG diagnosis as per the criteria. And secondly for severity, which we are talking just now. But I think feasibility of doing PSG in every child, which has been recommended by ASM, is not possible in our setting. So I would say what I think as a consensus was, if the child has simple OSA without any risk factors and has a proven clinical daytime and nighttime symptoms, I think adenotonsillectomy without doing a PSG is preferred or valid choice. But these children need to be followed and look for the residual symptoms, because some of them may have residual symptoms and you may have to do PSG. But if you have a complex OSA, I think it is must to get a PSG done, because you need to know what is the severity. Because if you have moderate to severe OSA in that complex child, then residual symptoms are going to be there, and these children at later age would need a repeat PSG. So that's the place of pre and post-operative PSG in these children.
Sure, the concept which everybody you brought out is very important, that there is a concept called residual OSA, which is shown to be around 25 to 30% of children who undergo adenotonsillectomy can come back with obstructive sleep apnea to you. So it's very important for you to do it prior because of that. Children with complex OSA, like Dr. Indu pointed out, are cases where you can't get away with not doing a sleep study. So these are the very specific indications that we do that. When do you use other modes? Like they spoke about pharmacological, he spoke about surgery. What about NIV? What are the indications for NIV with OSA, Dr. Preeti?
So we have already discussed those kids who have residual OSA, post-adenotonsillectomy will be one of the indications for using NIV, because it causes basically a pneumatic splint. It will keep the airway patent by causing a pneumatic splint, and so the children will not have these apneic episodes. Secondly, if the patients, they are not suitable for surgery for any of the reasons, like some of the medical conditions, the patients are not suitable for to undergo adenotonsillectomy. In few cases where we have small adenoids and tonsils, and we are not like confident enough, like post adenotonsillectomy, that the adenoids and tonsils only are the reasons for this apneic or the hypopneic events. So then in all these cases, NIV is an option. As well as in few of the parents, they are very adamant that they don't want to go for surgery, and they will say like, we'll go for any treatment, but defer surgery, we don't want to go for surgery. Then in those patients also, this NIV is a very good option. At least the child will not have all those hypoxic events, fragmented sleep, and all those symptoms of OSA.
Sure. So
I think in neuromuscular disorders also, we need to think of NIV, and that could be tonsil adenoid removal could be a stepping stone, but in these kids, you definitely need NIV. Complex OSAs, like children, again, with Down syndrome, with tonsil adenoid, you would land up using NIV. And of course, children with craniofacial and all other complex, their NIV generally comes ahead of tonsil adenoid. So you may add on, you may have to do both. But
like Dr. Indu pointed out, when we release that list of complex OSA, all those children who come in complex OSA tend to prefer NIV versus surgery and pharmacotherapy. So pharmacotherapy, as per studies, is recommended only in children with mild OSA. Surgery with or without NIV is recommended in children with moderate to severe OSA. Pre-operative PSG has strong utility prior to adenotonsillectomy. Post-operative one is required only for those children who have risk factors where you need to evaluate for residual OSA. I think this is the last question, and we will finish with this. How do we manage parasomnias in clinical practice? So we need to understand that you see a lot of parasomnias, sleep talking, sleepwalking, night terrors, nightmares, right? So what we have come to the conclusion is that all parasomnias have a single line of management, and then there are specific for each of them. So I think that was what we came across with our consensus, that Dr. Bafna, can you highlight, firstly, what are parasomnias? What comes under this broad category of parasomnias?
So parasomnias are basically unpleasant, involuntary physical activity or maybe behavior, abnormal behavior which happens during sleep. And they may happen during REM sleep or non-REM sleep, and depending upon which phase they happen, you will get non-REM parasomnia because in the first half of sleep, whereas REM parasomnia you will get in the latter half of the sleep. So as you have just said, the non-REM parasomnias are your sleepwalking, confusional arousal, night terror, whereas REM sleep you will get nightmares and other REM-related sleep disorders. So in non-REM, basically there is no amnesia. There is total amnesia of this event, and there is a disorientation, there may be agitation and autonomic behavior. Whereas in REM, you will remember what actually went on during the night. So that's the difference between parasomnias.
So parasomnias is the abnormal behavior we see in transition during sleep. Non-REM and REM parasomnias are the two types of parasomnias that you need to differentiate, as Dr. Bafna pointed out. And I think Dr. Indu will cover what are the overall steps of management of parasomnias in children. Remember that as Dr. Bafna pointed out, there are different types of parasomnias, but as an expert, initially we prepared consensus for each parasomnia. And then we realized that there's so much overlap that we combined all and said we'll prepare steps for parasomnias overall. Dr. Indu?
The first thing is you need to reassure the parent that these are benign conditions and the child will outgrow this with time. So if I were to broadly say, non-REM parasomnias are night terrors and confusional arousals, and the child gets up on his own and in these times, and then the child is actually not awake and has no memory of these events the subsequent day. So even if you try to wake the child or lift the child, in fact that is detrimental. So parents should just calm the child and just hold the child and soothe the child as needed. And if if the child is having nightmares, which is a REM parasomnia. The REM parasomnia occurs later in the night when the REM sleep occurs, and this is the time that the child actually gets up crying, shouting that he has seen a ghost, and he has memory of this event the subsequent day. So these children can be managed by giving them a happy ending to the story. So maybe for a week or two before the child goes to sleep, you talk about the nightmare and tell them, okay, a ghost doesn't occur and we are always there to support you, etc. And if you give a very happy ending to the whole story, maybe the child will grow out of this REM parasomnia, which is called nightmare. What is most important that these parasomnias, one is run in families. Secondly, it is important that the child should have a good sleep hygiene. If the child does not have a good sleep hygiene, these parasomnias automatically increase. So all the steps that we have already mentioned to you, that you must enforce good sleep hygiene, and parasomnias typically occur in school-going children. So when the non-REM sleep is a higher component. So you must ensure that they have a good sleep hygiene and a good environment, and very important is safety. So some children have sleepwalking, which is also a parasomnia, which is again a non-REM parasomnia. Child has no memory of it the subsequent day. So child might just walk out of the house, may go into the kitchen, may injure himself. So you should ensure that the child is safe. That is extremely important. Maybe lock the door so that he can't open the door and go out of the house. You must avoid caffeinated drinks before bedtime. Again, basically parasomnia is when the wake cycle and the sleep cycle intermingle with each other. So if you give caffeinated drinks, that could increase the wakefulness in the sleep. So sleep hygiene, again, is very important. Avoid digital screen exposure 1 to 2 hours prior to bedtime. And one thing is very important, that drugs are very, very rarely needed for parasomnias. So I would say that educate the parent, look at the safety of the child, follow good sleep hygiene, and tell them that the child will outgrow it, and happy ending for a nightmare and no drugs. This
so
is
a
how
lot
I
of
would
it is, as you
conclude.
mentioned, is behavioral counseling itself. Pharmacotherapy is not recommended. Polysomnography is not recommended in children with parasomnias. Okay. So any specific parasomnias, I think Dr. Indu covered all. Just one point on any specific parasomnia, anything different, Dr. Preeti?
I think this cognitive behavioral therapy ma'am has not addressed. We can use it for recurrent or repetitive nightmares if they are occurring, and then this cognitive behavioral therapy has a role. Plus, if we can have a discussion with the child on one-to-one basis regarding what kind of dreams the child is having, he can write it down, he can draw it, and we can end it with we can have a happy ending for that. This is called like image rehearsal therapy, so that these all techniques can be used. Night terrors, they do not need much consideration because the child do not have much memory, so child is not disturbed. It's very difficult, it is very horrifying for the parents to see the child having night terrors, but the child is otherwise very comfortable because as soon as he gets up, he has no memory for that event.
Sure.
So
I think overall, like Dr. Preeti covered and Dr. Indu covered, overall parasomnias require a broad spectrum of management, and that was the last statement that we mentioned, that parental education, support and counseling are the key steps for management of parasomnias. Pharmacotherapy is rarely recommended. So as you saw in a consensus statement, we have covered the entire broad spectrum of sleep. All questions which pediatricians generally have raised with us have been answered. Hopefully a lot of your questions have been answered. A lot of it will be released as a as a document which you can read through and use in your clinical practice. We just wanted to know in this group if you had any questions which are not answered, please feel free to add that question to us so that as an expert group we can look at literature and come up with an answer for a general pediatrician as well. So thank you to the panelists, Dr. Indu, Dr. Preeti and Dr. Sanjay Bafna for this excellent deliberation.
Thank you very much, Dr. Bharat Reddy.